Hi, this is John Kanelopoulos. We're in our center here in Athens, Greece, the LaserVision Ambulatory Surgery Center, and it's really my pleasure to try and explain to you the concept of ray tracing and how this fascinating technology can be used to customize LASIK treatments. It's not a new concept. For many years, ray tracing has been attempted, and there's clinical data with doing manual calculations. But we're going to go into a newer era. We started working with this technology as soon as it became available in the European Union, which was November of 2019. So we're in our third year now. And in essence, it all starts with a diagnostic device, which is a adapted Oculus Pentacam HR AXL wave. So it's a single device that's able to give us three different measurements. It can give us a high resolution pentacam, and we can see it here. This is the display from the device, which in Alcon language is called the sitemap. SITMAP. So the sitemap, after we're measuring a human eye, can give us pentacam HR measurements, and these are the measurements here, and they are quantitatively and qualitatively judged by the device, and there's certain criteria for each one of these measurements to be accepted, and we need 5 measurements at minimum in order to be able to have a pass. Then the device itself has, in essence, a lens star. We can see here the interferometry measurements, and we have several interferometry measurements. And last, Hartmann-Shack wavefront analyzer, which again takes several measurements, and these measurements need to have consistency between them and accuracy. And also, the measurement is a go if the actual refraction measured on the wavefront is within half a diopter, 1 diopter of the manifest refraction that we're measuring with the patient. So there's another element here of safety where we're trying to avoid a patient accommodating in the device. Last, the device also is able to register iris anatomy and limbal anatomy with an infrared capture of that, and in essence give us, as you can see there on your right side, 3 sets of measurements. And the way this works is that initially, with the first set of measurements, the axial length measurements, and it's just not just the axial length, it's in essence all the interferometry measurements, the distance of the anterior chamber, the thickness of the lens, and of course the vitreous cavity. So the data from the lens star are initially used so the device constructs a 3-dimensional avatar of each eye of a patient. So a 3-dimensional model of each individual eye studied with the sitemap is being constructed by the software. And then the pentacam maps are used to study 2,000 rays from the pentacam device traveling through air, inciting on the anterior surface of the cornea, through the cornea, coming out from the backside of the cornea into the aqueous cavity, anterior chamber cavity, and then reaching the front part of the crystalline lens. And that's the towards the eye 2,000 rays of ray tracing. Following, the wavefront data are used to study 2,000 rays again in a retrospective fashion from the surface of the retina through the vitreous cavity, going through the posterior part of the crystalline lens, through the crystalline lens, and to the anterior surface of the lens. So in essence, this technology, and we're going to shift a little bit to what we talked about before. We have the 2,000 rays studied from the scientific part of the sitemap device towards the eye, and then 2,000 rays from the Hartmann-Shack going from the retina to, again, the front part of the lens. And this is able to give us data, automated data. This is all done by artificial intelligence of low-order aberrations, so the amount of myopia and astigmatism and axis, and high-order aberrations, coma, trifle, etc. The measurements are very consistent. These data transfer automatically into the EX500 excimer laser through the Innoveyes platform, customized platform. We have worked with this technology, as I mentioned, for over 2 years now. We've published our initial clinical data more than a year ago. We were very fortunate to run our own investigator-initiated study with Alcon and also be part of a second study that was a multi-center study throughout the world, included countries in the European Union, Germany, Spain, us in Greece, and Australia. And the data are really, really outstanding. And we'll see a little bit as part of our presentation in the last year's meetings how these data resonate, the accuracy of this technology, and how it is able to consistently improve the way we approach laser vision correction. We all know that wave front optimized treatments with any laser platform give outstanding results. It's quite expected, I should say, in our days to achieve 20/20 vision with any excimer laser under any platform, customized or not. If we're pursuing not just 20/20 vision, but the ability to, besides correcting the refractive error, improve the optics of each individual eye, because we know the cornea is not always lined up with the line of sight, so there's angle kappa. Even regular astigmatism can act as a prism. I omitted to mention that one of the key elements with ray tracing is that it also calculates the tilt between the cornea refractive surface and the lens as a refractive surface, and this opens a great window in treating keratoconus, and we published on this in the Journal of Cornea as well, because in contrast to all the work that we've done in treating cornea irregularity and keratoconus with a topography-guided normalization, which views the cornea only, the Innoveyes software views a ectatic cornea, which usually is ectatic in its inferior part, as a cornea that is tilted. So its correction to that tilted cornea in relation to the rest of the eye as a visual system, as a refractive system, is that it treats very little at the peak of the cone, which is the most steep part of the cornea, and more away from the mid-periphery of the cornea as a hyperopic arc where the cornea is usually thick, thus obtaining remarkable normalization of the cornea with very little treatment over the thinnest part of the cornea, which is the peak of the cone. So we're going to go look into some data from our clinical work with the fascinating ray tracing software and how this resonates its ability to not only effectively correct refractive errors, but also obtain better contrastivity than before the surgery. This is very impressive, and also gain in more than 65% of the patients of one line of vision when we compare best corrected vision prior to the surgery and uncorrected vision after the surgery. So let's go and look at the clinical results from meetings of the recent past.
Hello, this is John Kanellopoulos, and on behalf of our associate Dr. Vasilis Kouteris and the LaserVision Clinical Research Institute in Athens, Greece, it's really a great pleasure to share with you these outstanding outcomes using a customized technique that is novel, ray tracing, optimization. The purpose was obviously, and I want to point out here that I do consult for Alcon, and this was a study sponsored by initiated trial by the investigator, which was myself, number 59917561 from Alcon, Greece. And we looked in the study the safety and efficacy of using this new ray tracing platform to customize myopic LASIK eyes. To note here that this technology does carry a CE mark since the fall of 2019. And in this particular study, we chose to study 25 consecutive patients, 50 eyes that were treated with femtosecond laser-assisted LASIK using the FS200 femtosecond laser and the EX500 excimer laser by Wavelight Alcon. And the key element here is that we used a novel artificial intelligence platform that initially calculates the ablation profile based on the model eye of each eye, which is created by the interferometry length data. And then through wavefront and pentacam measurements, it does calculate low and high order aberrations by studying 2000 rays going towards the eye and from the eye on this theoretical 3D avatar eye model. So we looked at the usual visual acuity data, which were refractive error, uncorrected visual acuity, corrected visual acuity, keratometry, topography, tomography, high order aberrations, and contrastivity for a year. Just to backtrack here a little bit, we have introduced and reported subsequently how important in our clinical experience was adjusting the manifest cylinder in topography-guided treatments with also Alcon's topo-guided contour platform. We showed and published in 2016 that TMR data proved superior to those from topography-guided treatments where the treatment was based on the manifest refraction from each patient. So we theorized that collecting all these data and manually calculating the cylinder to be treated gave an advantage in these eyes clinically, and this work appears validated by this new device. And here is the device called SightMap. It's basically an Oculus axial length Pentacam HR wavefront device, which is configured by the Alcon Wavelight team to collect these three measurements from each eye of each patient, interferometry data, sine fluke tomography, Pentacam HR, and wavefront data using Hartmann-Shack concept. And you can see the report on the top left here on how these data are incorporated to produce the model, and the model of each eye is calculated. On the top left, we can see the interferometry data that are used for the device to formulate a 3D model of each eye that it studies. Then on the top right, we're seeing consecutive Pentacam measurements, and there's certain protocol on how similar and homogeneous these measurements need to be in order to be accepted as a go-to by the device, and so on with the wavefront measurements as well. And also during these measurements, iris recognition and pupillarimetry measurements are taken. We have a detailed tutorial on the YouTube portal that you can see here, and you're welcome to jot it down and visit it to complicated concept. So just to summarize how automated ray tracing takes place, in the first step, as I mentioned, the axial length measurements produced by the same SightMap device give the opportunity for the software to create a 3D model of each eye, an avatar eye, and then the tomography measurements with the Pentacam are used to trace 2000 rays from the device through the air, cornea, aqueous, and incident to the anterior surface of the lens of the eye. And then 2000 rays are again measured in retrograde with the wavefront data from the retina through the vitreous cavity, incident in the posterior lenticular surface through the lens to the anterior lens surface. And these data are then coordinated to create high order, low order aberrations. So in low order, the amount of myopia and astigmatism, high order aberrations, mainly coma and trifocal, and also the tilt between the cornea refractive surface and the lenticular refractive surface. And this is a key element to the concept, and thus is able to provide with very detailed data for aberrations. So to go to results, these are the best results we've yet to see in refractive surgery. And I mentioned before, these are 25 consecutive patients with myopia and myopic astigmatism of up to 8 diopters. The 3-month data, which were stable through 12 months, showed an average refractive error of about -5 with broad range, as you can see here, up to -8. And refractive astigmatism of average about -1, but with a broad range of up to 425. The refractive astigmatism was also studied in means of topography, the topographic objective astigmatism measured by the Pentacam, And we saw that 65% of eyes gained at least one line of vision, and 38%, this is an astounding number, gained 2 lines of vision when comparing preoperative corrected visual acuity to postoperative uncorrected visual acuity 3 months, 6 months, and up to 12 months time. So the pre to postoperative higher aberration average had very little change, and this is again a new thing in refractive surgery, an increase of higher aberrations from 0.25 preoperatively to just 0.35, and this reflects in the contrast sensitivity data that you can see on the bottom right, the F image on the compiled refractive data, which show that the contrast sensitivity was actually improved postoperative than preoperative. Very, very impressive data. Right here, we report safe and effective preliminary outcomes using this novel excimer laser customization by ray tracing optimization with this Alcon Wavelight platform, using a configured device by Oculus and named sitemap by the manufacturer, and the treatment is called Innoveyes. It is still under study in a multi-center trial in the US and international, and the preliminary data from those studies are very similar, and we're exploring all the possible promising possibilities in using this technology to treat quite irregular eyes such as keratoconus. We do have a case report that's being published in the Journal of Cornea, underlining how the use of this technology can overcome some of the hurdles in calculating total eye low order and higher order aberrations, even in very regular eyes such as keratoconic eyes, and also the possibility of combining it with cornea crosslinking. Thank you so much for following this very difficult project to describe. And this is John Kanellopoulos on behalf of Dr. Vasilis Kouteris and all our team here in Athens, Greece. I hope you enjoy your meeting. Thanks so much.
Hello, this is John Kanellopoulos. It's really a pleasure and an honor to share with you some of the work we have been doing for the last 20 years in combining surface excimer ablations in very irregular eyes, such as and we do have in YouTube, for those who are beginners in this endeavor, a very careful look on how cornea imaging has changed through the years, and I would recommend for those of you who are not very experienced with cornea imaging to take a look at this. It's at our channel, the LaserVision channel. And in essence, topography guided was designed in Europe back in 2002-2003 as a tool to treat irregular corneas. And you can see here on the left, enlarging an optical zone. On the bottom, we have a cornea scar from contact lenses. You can see how in the bottom middle comparison pentacams, the inferior cornea is flattened from the scar. The superior cornea appears to be steeper. It's kind of like a upside down keratoconus image, and how with topography guided we're able in the middle to almost perfectly normalize this cornea. Of course, this is the anterior corneal surface, and we can see the difference map on how detailed topography can be in normalizing the cornea. And of course, the literature back in 2007 of us endeavoring with topography guided in ectasia and how it can dramatically improve in these patients. And this is where the Athens Protocol was born, combining a partial in the amount of refraction corrected topography guided surface ablation with higher fluent CXL, mitomycin C. And a little bit bizarre that we first treat the topo guided PRK and then we account for the epithelial removal, either 50 microns or 40 microns in an 8 millimeter diameter, because the first step is more sensitive to cycle rotation, thus the change in sequence. The typical results, and I'll draw your attention to the picture on the far right where we have a flattening effect of 10.3 diopters, and this is the key essence of combining surface ablation and CXL, obviously in patients who are intolerant to contact lens use, because we're getting a triple or quadruple amount of correction if we compare it to what a very mild and refractive error topography guided PRK would produce, or CXL alone. So there's significant synergy and dramatic improvement of the, and we presented at this meeting several years ago, It has been published now, the 10-year outcomes show that after the first year, we don't see much change here. Our patients plotted through the years, and we reported over 2,000 literature 3 years, to include here pediatric patients who appear to benefit as well. And long-term curvatures. Here's the keratometric regression, and what we like to use as a tool to assess these eyes, the index of height decentration. Pediatric patients think work very well. We've worked on customization on the CXL side as well. This is a tool available outside the U.S. By Vidronal Glaucos. It is the Mosaic device that is able, and I'll draw your attention here to the lower right image, which in essence shows us a different pattern of CXL produced by different fluences in different shapes, and it is catered to the thinnest part of the cornea. And this is an OCT thickness map. You can see the smaller green kind of ellipsoid trapezoid is delivering 15 joules of energy. So this is pretty much 3 times the Dresden Protocol. The larger blue elliptical trapezoid will deliver 10, and then the circle, which is the red circle, which is 7 millimeter in diameter, will deliver the classic 5 joules, pretty much similar to the Dresden Protocol. So within one treatment, this device has an eye tracker, so it does deliver where it's supposed to. We're treating preferentially more at the thinnest part of the cornea, and this can attain significant refractive effect. Thus, when we're combining a partial and refraction topography guided PRK and CXL, we can remove even less tissue and get even more of an effect. And this is a case here. We have reported this almost 5 years ago in the literature. You can see left pre-op, right post-op, the dramatic improvement in visual function. The last thing we've been working on is ray tracing optimization in virgin myopic LASIK eyes, and we thought that this technology application in treating irregular eyes as well. And in essence, just to familiarize you briefly, in this last minute that I have, ray tracing uses 4 steps. It first measures through a single device, the SightMut device in Alcon language, and I do consult for Alcon. It measures the axial length stations within the eye, and then designs a 3D avatar eye for each eye that's being examined, and then uses the Pentacam rays to do towards the eye ray tracing, and the Hartmann-Shack wavefront rays from the retina to do retro ray tracing for aberrations. And so we use this technology, and we're reporting this in the Journal of Cornea in keratoconic. The very significant advantage, and I want to underline this, that is that an ectatic cornea, flat superiorly, steep inferiorly, is viewed by this technology as a tilted cornea. Thus, when it's trying to normalize the optical system, it treats more the superior hyperopic arc and moves less from the advantage here, plus treating higher aberrations from the posterior cornea surface. This is the latest thing we're working on, and we're very excited about it being able to address some of the extreme refractive errors. For your attention, and thank you for supporting us through all these years in treating these ectatic and needy for improvement eyes. This is John Canalopoulos signing out.